panel. Liz is recording now. I'd like you to introduce yourselves that are here so that the people online know who we are. Okay, shall I start? Sue Jones, Chair of this Adult Services Scrutiny.
Liz Jordan, Scrutiny Officer.
Tony Beddow, Independent Member of the panel.
Councillor Hayley Gwilym, Cabinet Member for Community Support.
Sue Clairage, Early Help Principal Officer.
Lucy Friday, Principal Officer for Transformation in Adult Services.
And my name is Michael Locke. I'm the councillor for Sketty.
Amy Hawkins, Head of Adult Services.
Thank you all. Right, item 1 is apologies. I think we've had apologies from Alan Jeffries, Louise Gibbard and Chris Holly at the minute. Are there any others?
No, Chair.
All right. Lovely. Disclosures of interest. If there are any, can you email, Liz will email you the template for completion. Are there any? Thank you. Prohibition of whipped votes and declaration of party whips. Okie doke. Item 4, minutes of the previous meeting. Can I at this time thank Paxton for coming in when I was on leave. I was in Alaska, which was lovely. So thank you, Paxton, for chairing last month. Minutes of the previous meeting there are page 1, page 2, page 3, page 4, and page 5. Can I take your silence as a true record of the last meeting? Yes. Thank you. The letters are item 4. Okay, Miranda, you want to speak? Oh, sorry, more 6s and 7s. Miranda, welcome to the meeting from Llais. This is your first meeting. Lovely to see that you're attending. Thank you. Right, item 5 are the letters. Are there any comments on that? No, we're going like a bomb at the minute, aren't we? Item 6, public questions. Are there any, Liz?
No, we haven't received any, Chair.
Okay, we go on to item 7, which is the early help update. Who's leading on this item? Hayley, thank you.
Yeah, thank you, Chair. Just to briefly introduce, and then I'll hand you over to Sue Parage. Obviously, it's her report, but it's always a great opportunity to come to scrutiny so that officers can talk not only about the great work that they are undertaking, but also touch on any challenges faced or experienced, and also answer the committee's questions. So today, as we discuss early help, it's important, I think, to note that we are very early in this direction of travel. We've committed to this approach, which is the target operating model. It supports people at the earliest opportunity, not only to promote safety, but also independence and better outcomes for our population before the need for managed care. So we have Sue Parage, who I mentioned. She's been newly appointed as the Principal Officer, and Sue is very experienced, having worked previously within early help, child and family services. So she's got a proven track record in regards to early help in delivering, and I've got great respect for Sue and great faith in her, and from conversations that I've had with officers who are working within the department, they're very positive about the approach that's being undertaken, and they're feeling really good about the way in which they're going to be promoting, but working with our population going forward. So I'll hand you over to Sue to take you through the report.
Thank you, Hayley. Sue, welcome.
Thank you, and thank you, Councillor Gwilym. So as Hayley has said, I am going to share with you some
data in relation to performance for early help, but I would like to take this opportunity as well just to share with you some of the next steps, because we are early into our journey. We've got a great ambition that aligns to our adult services target operating model, but I felt I wanted to give you a balance of looking back and looking forward. So as you know, early intervention and prevention is one of the core principles of the Social Services and Wellbeing Act, and the early help focus is very much about giving people voice and control and independence and reducing pressures on statutory services, making use of statutory services when they're appropriate, but right-sizing that support as and when we can to ensure that we are stepping down or maximising on the opportunities within early help and enabling community resilience. So the approach does involve working alongside colleagues in enabling communities and with our third sector providers and other providers such as health. And in order to achieve a strategic joined up approach that is more of a systems focus than just focusing on what the local authority can do, we have created a new number of posts, my post being one of them, as well as a strategic lead for commissioning and a strategic lead for the third sector. The early help team, as is in adult services, is made up of a number of different roles, including advice and information workers in our common access point. We have a sensory team, we have community wellbeing officers, and we have area coordination. And coming together as one large early help team, we offer information, advice and assistance. We have assisted technology, equipment and assessment support. We have vision assessment and rehabilitation support, including technology support for people with sensory impaired issues. And where required, we can access our statutory partners and our rapid response team for social work intervention. Community-based solutions remain central to our offer, and we are always trying to build social capital and community capital, because that's where we believe real resilience lies, as well as managed care. So in terms of performance update, I'm going to quickly run through some of our key headline measures. So in 2024-25, the total number of contacts into the early help common access point decreased by 11,225. So this equates to a 24% reduction on the year before. And then the new contacts in the first 6 months of this year, 5,096. Between April and September 2025, the team received 2,467 new contacts. And I think the bit that I want to pull out here is that just over 53% of them were supported via an early help offer with information, advice or assistance or signpost. In 2024 to 2025, 209 adult carers were supported with specialist information, advice and assistance. And the first 6 months of this year, we've seen 109 adult carers be supported. So in terms of our data for this year, the indication is very similar to last year's data. In January 2025, we joined in partnership with Swansea Council for Voluntary Services, and we developed a new role called Community Wellbeing Officer. And as part of that role, the officers support adults for up to 3 months of brief intervention, rapid response type practical support. And what we've been able to see since January and June of 2025 is that 125 adults were supported in this way, with 107 of those adults remaining in support that is provided either by the third sector or early help. So no further requirement from statutory provision. During 2024 to 2025, the area coordinator supported 3,463 adults and carers with information, advice and brief intervention. Between April and August 2025, 1,225 adults were supported. Sorry, I think I've repeated myself for that. I got a bit lost. Out of the 1,223 adults, 471 of them were supported with longer term needs. During 24-25, the reablement home care team supported 629 people with around 46% of those people requiring no ongoing care. Then between April and September 2025, 406 people were supported, with around 36% again requiring no ongoing care. During 24-25, residential enablement supported 248 people, with 46 requiring no ongoing care and 34% returning home with care. Again, really proud of that data. And then between April and September 2025, 138 people were supported, with 54% requiring no ongoing care and 22% returning home with care. So that's a retrospective look on some of the key data that we wanted to share. But as I mentioned earlier, I'm quite keen to share with you some future developments and some next steps. And in relation to our common access point, we get, as you can see, we had around 53% of our callers supported via an early help offer. One of the things that we're really keen to do is introduce the concept of thematic codes for calls where we close with an early help offer, so we can start to build some intelligence of what it is that people are ringing our front door for information on, so we can use that to work backwards into our community and use our partners to maybe share key messages or strengthen or profile areas that people come into support for, but actually that support can be got elsewhere. So that we're quite excited by the possibilities of what that work can bring us. We're increasing investment in our community wellbeing offer. I think we saw that out of the 100 and something, 107 were supported with no ongoing further need. So that's something that we want to expand on. And we've had significant additional investment to recruit to early help lead worker posts, supporting independence from post-hospital discharge and preventing readmission into hospital. We've also appointed a new full-time vision rehab specialist, and that team will have grown significantly into 3 people. So we have greater capacity to support with information and daily living assistance skills. And then some of the further steps will be to strengthen our public awareness of early help, get stakeholders to sign up to our shared vision, recruit. We'll have a big recruitment drive in terms of early help lead work. Hospital discharge, as I said, is a significant area. And then to maximise on the opportunities that our third sector strategic lead and our commissioning lead provide with us in terms of what we can do via aligning some of that early help work, and then creating existing and building on new pathways of support to ensure that we offer the right support at the right time to as many people as we can reach. And I think that's probably about it, unless anybody's got any questions for me.
Thank you, Sue. Anybody got any questions for Sue? Cheryl, would you like to ask a question?
Yeah, thanks, Chair. Thanks for the report. I mean, it's absolutely amazing that people have been either self-referred or they've been referred to social services, and then we find that with the support that they then need no ongoing care. But I found that I wasn't sure how that has worked, because if people have had a referral to social services, on what basis was the assessment made that they need no ongoing care? I'm a little bit concerned about that the assessment may be too sort of like, maybe I don't know. I just got this sort of like concern, and I can't really voice it, and other than that it seems quite strange that with that many referrals that basically 40% need no ongoing care. So what what was the basis for that? What care did they have? What enablement did they have then not to get there?
I'm happy to offer.
Sue, are you going to?
We'll just
Lucy,
all 3 of us.
yeah, okay. Who's first? Lucy, you go first.
Yeah,
Yeah.
thank you, Chair. Thank you for the question. Yeah, you're quite right. I mean, I mean, this is in line with our model of delivery. So the particular example that Sue gave in her report relates to, I think this is the data that you're referring to, does relate to reablement provision, so specific, so a referral to a reablement service, whether it be reablement at home through our home care service, or whether it be reablement in a residential setting. So part of the role within that is actually partly assessment at the same time. So, and it's very much around the functional care needs of the individual. But of course, throughout all of that, the assessment conducted, and there is social work involvement, is around strengths-based practice. So it's about looking for, you know, what are the outcomes that that individual wants to achieve. So all decisions are mutual, to offer some reassurance around that, but it's also largely about enabling people to return to physical independence or return to living at home independently. And that would often be in conjunction with not just social work conversations with the person, carers, but also therapy input as well. It might be with the use of equipment within the home setting as well, that person's able to remain at home and live independently. It is a really positive outcome. I can understand why you would ask the question, but it is with that hope that that would be the best outcome for that person, would be able to remain at home independently. So I think that is the data that's being referred to. I don't know whether Amy or Sue want to add to that.
Can I just add something about those that come to the front door as well? So those initial referrals that come in as well. So again, to give you that reassurance really that this is a key part of our offer, I suppose, that we want to first and foremost support people to remain independent. So if we can do the least intervention, I suppose, and just light touch support for people, so we don't go in and suddenly say, right, we're going to send carers around 3 times a day to support you. You know, this is about saying actually what's the minimum that you need, but the minimum you need to stay safe and well. So that's the support. And I think that the key words, I suppose, in there is about this isn't just someone coming in and we say, oh, we can't help you, goodbye. You know, this is people are provided information, advice and assistance. So that could be a referral to one of our partner organisations. It could be one of our own team providing that ongoing light touch support. But it isn't about having a social work assessment, a care and support plan, you know, an annual review, a financially assessed package of care. So it's about much more community-based services. So I don't know, Sue, sorry, we thought all 3 of us would have something to say.
Yeah, I would just reiterate what Amy has just said, so that we have a statutory function to provide information, advice and assistance. And I think that if people don't know where to go to, they naturally default to CAP for that information, advice and assistance. And as Amy says, it's not that they get told no and they don't get anything. They are signposted to the right support at the right time. And I think that's why those thematic wrap-up codes will be really interesting going forward, because we'll have much greater intelligence on why people are coming to us in the first place, so that we can build that community resilience more locally, and we can start to unpick why it is that people come into CAP, because actually they're bouncing in and we're bouncing them back out again, when actually what we want them to do is, if they feel they've got an unmet need, that they know where to go to, so that they don't have to be over processed, if that makes sense.
Okay, Cheryl.
Yes, thanks. Perhaps one to, as I say, because on paper it looks absolutely marvellous, doesn't it? And that's what we do want. We do want people to maintain their independence. I just wouldn't want sort of, you know, to find that you've just used the expression bouncing in one door and then out through the other. Would hate to think that 3 months down the line, somebody who could have perhaps had the early intervention of assistance and help then finds, because they feel that they should be doing it themselves, and come back in, even though they might have had the independence for 3 months. So just something I think to keep on in mind. But thank you. Sounds excellent. Thank you.
Yes, I understand what Councillor Philpott is saying. This smacks very much like the area coordinators that work on the ground in the wards are doing. So it just seems to be a confusing comparison, or am I not on the right track?
think it's about joining up all the dots. I think one of the things that we're going to be doing in January is we're going to be all be moving on to the same management information system. So we'll have much more robust data. So that stuff around repeat referrals, that stuff around where we've closed adults with the support and whether they come back into the system is going to be something that we'll be much more robust on going forward. Because currently, as it stands, we've got 3 different databases in operation. But we, you know, as of January, we're all on the one system. We'll have much better data on capturing that.
Okay, so you've got no figures for us for re-referrals as such because you're so early, yeah? Obviously, we'll... Amy, you wanted to come?
No, can I just add it as well? When you said it sounds like area coordination, that's because area coordination forms part of early help as well. So it is one of the teams that is a part, as Sue mentioned. Yeah, so it's one of the pathways of offer could be area coordination. It could also be some of our community wellbeing offers. So it could be some of these new early help lead workers. Could be a sensory support worker. You know, we're about developing a lot more of our early help workers so we can provide that right support at the right time. And then where needed, again, absolutely understand the questions that have been asked. There's that safety net. So when people do need then to come into managed care, we are able to have the resources available to do that. Whereas at the moment, if everyone comes into managed care, of course, we end up with waiting lists and other scenarios. So this is about really providing a much earlier holistic offer to people to support them. So yeah, if it sounds like something you've got already, it's that plus, isn't it? Is that fair?
Thank you, Amy. Yvonne, you've got a question.
Thanks, Chair. It's following on from Councillor Philpott. So I was just wanting to be clear. For example, someone comes in and you've had them fill the form in and you've directed them, for example, to SCVS. It's closed then, am I right? Because there's nothing else you can do. But if I am understanding, if they come back, you'll have a record and you then will look at why have they come back?
Yes, so we'd want to know what support has happened previously. We'd want to look at what you know, is it the same reason they're coming back in, or is it a different reason? So when we're all on the same systems together, we'll be intelligence rich. At the moment, we're not on the same systems together, so some of that is really difficult to work out. But yeah, we will be in a position where.
Sorry, go ahead.
We'll be in a position going forward that we'll be able to join up all of that information and we'll know numbers of re-referrals. So we do at the moment for CAP, our common access point, but we don't know all of that for all of the different teams that are joining us or have recently joined us for early help.
But when you've given them, let's say for ease of reference, the information and they go away, is that when you close your case and there's no further support provided?
So it might be an early help. There are multiple providers providing support for one adult and it will be coordinated with the area coordinator playing a role in brokering in support so that it's a bit like a jigsaw puzzle. People with, you know, strengths around securing benefits or housing may be part of that package of support. But if you're talking about people coming into CAP and closing, then people would come in and be given information, advice or assistance and then handed over to an organisation. I think you referenced Swansea Council for Voluntary Services, who may support for a bit. That adult may come back
but
in.
For your books, at that point, does it become no further support action is needed?
If it was
when
in
you
CAP,
refer them on?
Yeah, if it was in CAP, it would close down. If it was part of a multi-agency coordinated offer of support, it would stay open.
Okay, thanks. That's what I was trying to
do.
Thank you.
Okay, Yvonne. Councillor Tribe.
Thank you, Chair. I just want to clarify, you may have answered the question already, but we do rely heavily on our local LHCs, who are a fantastic team. We meet up monthly because normally it's either the ward councillors or the community councillors are the conduit for people to access extra support services. Do we still maintain that strategy where we use our LHCs to access these new projects? Thank you.
Yes, the area coordinators are very much part and central of the early help offer going forward, yeah.
Thanks very much.
Thank you, Councillor Tribe. Any other questions? Can I just ask, is there any progress in maybe extending the area coordinators, local area coordinators, because they are on the ground, and I know as a councillors, we, as Councillor Tribe said, rely very much on them.
I just come in on this. So I suppose what Sue's outlined is our new area, our new early help teams. So we have extended it dramatically, significantly. We're about to go out to advert. We'll do some press around the advert as well. Actually, we're talking to Councillor William about this as well, to let the public know how many more early help workers we're having. So there will be numerous team members people can support with. So in terms of extending area coordinators, no, not as an approach. I think we've got full county coverage in terms of the area coordinators, but they form part of a puzzle of, not a puzzle, sorry, don't want it to sound complicated. They form part of a network of support workers, of which we have access to now, that we're directly employing, that we're working in partnership with partners like SCVS to deliver. So I think, yeah, no on one answer, but you are getting more now.
That was one of my questions, how we were going to make the public aware of this system.
Yeah, we're going to be doing a lot of comms work, and we're going to be using our area coordinators to disseminate that message. So we've got lots of different avenues that we want to pursue in terms of raising the profile of the early help offer across, and not just solely on the places like internet, because not everybody uses the internet. So, you know, colleagues in where we've got community assets, you know, community buildings, information, advice and assistance in those places. So we've got quite a big comm strategy to start work on, yeah.
Again, are you involving the ward councillors in this?
Sorry, yeah, I was actually just going to put my hands up to add. Yeah, we've all got a role to play in this, and I think information is power, actually. So as much information as we can share with ward councillors, we absolutely will, and we can also then disseminate that information out to our residents, but we can also make referrals then where appropriate in via common access point or in our monthly meetings with our local area coordinators or other community workers.
Thank you, Hayley. Are there any other questions? Tony.
Thank you, Chair. As we've been talking about this, the sort of image that goes through my mind is whether your customers, and forgive me for using that term, whether there's a mix between the way your customers come to you fairly quickly as a matter of urgency because something has happened, they've either caught a disease, there's been an accident or whatever. And on the other hand, you've got a slow burning group of people, whether it's a mental illness, whether it's a self-esteem problem, whether it's a loss of friends and companies and whatever. I mean, what's the balance of the two, if we can stick with the two? What does that forecast in terms of those original numbers being added to as the help is put in fairly slowly at the minute, you know, because you can, and there's a backup set of demands coming along the road in another 3 months, 5 months, or whatever. Does that make any sense?
So the way that we're going to configure ourselves going forward is, you know, as Amy's mentioned, we've got significant investment come in, so we're increasing the capacity. But we're going to be splitting the team into a brief intervention, rapid response offer, and then a longer term community support. So we're confident, based on a retrospective look of numbers, that by shifting the focus on the way that we work, that we will have people in post who can rapidly respond in a timely way for some of that crisis intervention type stuff. So people who may need, you know, there's been an accident, or they need access to food parcels, or we need to check their benefits, or they've got housing issues, they've had an eviction notice, those sorts of things. And then we'll also have the community arm where we'll have a greater capacity to feed people in with maybe isolation and loneliness. So people who need longer term continued support, but not as frequent as sort of a top loaded support where people are feeling totally overwhelmed and can't see the woods for the trees. So based on what we know about how we've worked historically, we're confident that the model that we've got going forward can respond to that, and that, you know, there'll be a level of flex within that offer.
Any other questions from anybody? Oh, Amy.
I'm sorry. It's only because this is so in development and we're doing so much work around this at the moment. I've got more to add, but just I suppose some more reassurance as well for you as members and members of Scrutiny as well, that Sue's describing there our early help team as well. But in terms of that rapid response, we have our social work team as well. So where required, where a case needs to be escalated, we have our multidisciplinary teams working in a social work setting as well. So there will be social workers, occupational therapists, other health staff as well, so where needed. But the idea is, with early help, by definition, we want to help people earlier. So if we can, we can. But where needed, there is always that safety net that can be escalated through as well. So we make sure we've got, and in our usual performance reports, which you're going to see next, you'll see some of the information around that. We call it MDT, multidisciplinary team rapid response in our report, and that's when it's gone through that first stage and sort of can go through to the next.
Thank you, Amy. Paxton, you have a question?
Yeah, thank you, Chairman. Certainly a very interesting report, and it's something that I've had a chance to look through and read. But the question really that comes, obviously, you're looking at putting extra resources into the early help and what have you. That obviously costs money. Where are you going to save that money down the line? Because obviously you will know better than I do, I suppose, just how tight your budgets are currently, both in adult social services as well as child and family services. But in adult social services particularly, if you make an investment up front, what sort of analysis has been done already of the savings that you're likely to make as a result of that?
So we're just deciding who will answer. Yeah, we've done some analysis on this already, but some of this is the work that Sue's mentioned around that sort of, what this report is the start of around our performance information in this early help space. What we do know is if we can prevent or delay people going into managed care, then that is where our savings come from. So at the moment, you know, whilst people have to financially contribute towards, for example, dom care at home, we significantly subsidise that. So, you know, if we know somebody could be helped with some alternative support, it is more cost effective. And if people can remain independent at home, it is more cost effective than someone going into residential care. Certainly, if someone can remain safe and well at home rather than going to hospital, it's significantly saving. So, I mean, this is where the money is, but this isn't necessarily a cost saving. This is about having a financially sustainable service. So as you'll know as members from this year's financial budget, you know, you invested more money in us in social services to enable us to deliver what we can. And we're going through our budget cycle again at the moment. So this isn't going to be a massive cost saving because the demand is massive. You'll see from the August report that you've got next. We had our internal meeting yesterday looking at our September performance. The demand is coming up. We're coming into winter. You know, we know the demand is there. This is about having an offer that allows us to have a financially sustainable chance, really.
Thank you, Amy. Paxton, is that okay?
Just to say, I'm not quite sure what the difference is between savings and financial sustainability, to be honest. But that's an interesting point. But basically, what you're saying is that there's not been able as yet to do any sort of actual cost analysis to see the benefits. Obviously, we'll be looking at the performance reports after. It might well be worth trying to put the impact of what you're hoping to do into the same sort of into a similar sort of graph for the work that's being done in terms of early help, just to see, we can see the comparison perhaps that early help is then delivering what you're expecting to see in a reduction in the amount of more definitive support going forward. Sorry if that's been awkward.
Thank you, Paxton. I don't know.
Absolutely.
Yeah.
No, absolutely, we agree. Yeah, our whole performance information will be aligned to this. You'll already see the first few pages of the performance report is around our early help offer. But as Sue's explained, the early help offer is enhanced and becoming more expansive. So you'll have more information there, and we will link that back. I suppose what I was trying to say is the demand is still significant. So we might not necessarily stem the demand, but what we will do is be able to manage that demand effectively within the resource we've got. That's what we're trying to do. That's why I talk about the sustainable funding, but I appreciate, it's the language.
Thank you, Amy. Are there any
Yeah.
other questions?
I think that's what I trying to say is like we would hope to see the benefits in the figures further on in the report as a result of what you're doing as early help. So I
Thank
think
you,
probably I've
Baxter.
said enough on that now. Thank you.
Thank you, Baxter. Are there any, Tony?
Yeah, just to come back to the other discussion. In terms of balancing the quality of life and the quantity of life, within the quality of life, the measurements must be different depending on what the individuals have gone through. If they've got a long-term, illness that's finding its way slowly to the inevitable, that's possibly one way of bringing in the army to turn the battle back again and extend the quality of life and, by definition, the quantity of life. I mean, are those two measures of automatic use, or is there something else that will supplement them and stand in their stead for particular conditions?
Yeah, do you know, Sue and I were talking about this earlier on today about some of the work we're doing around a framework of measurements, and what we've got at the moment. And actually, we've been involved in some national discussions about what they're looking at around prevention, early intervention, and what's happening. We're looking at some research that's happening, and we're making some links to the university around some research. So at the moment, there are a number of measures that we have, but it doesn't, and there are sort of quality of life indicators, distance travelled, tools, there's different things that the teams are using, but we are looking at what will be the most effective one here. I think some of those about the amount of healthy years people have, there's some national measures around this as well. So at the moment, that suite of sort of performance information, we haven't fully concluded what we're going to use, and a lot of it's about asking individuals, isn't it? Of course, and what matters to individuals is always that central to the work of the team. So they're always asking people what matters, and it can be quite unique to each individual, so to try and then sort of align something in a framework. But yeah, certainly something is a key part of the work. As Hayley mentioned right at the beginning, this is quite new approach, this way of it. We've always done bits of work in this space, but to try and really look at it in this way. So which is, your scrutiny, we would be happy to bring you this again. This is about you as a committee sort of seeing this information in its each iteration.
I'm sure we welcome you to bring this subject again, because it is so necessary. As I've always said, loneliness is huge within the area, and if we can address people's loneliness, I'm sure we can help them to keep going. Thank you for that. No other questions? Tony, come back.
It's not a question, Chair, it's just a comment. I think I'm right in saying that in the days of the old Welsh Institute for Health and Social Care that sprung up probably 10 years ago now, that one of two of the measures, if you want to decouple them, two of the measures that were brought into use fairly early on was the notion of extending the quantity of life, particularly for particular groups, and extending in other circumstances the quality of life. And that data may still be somewhere in the backyard of an encyclopedia that has seen better days, but you might find something useful there.
Thank you, Tone. I think we've had a great discussion over this new system, but we are really all very interested, and we'll welcome you back, Sue. Sorry. Okay. We'll go on to the next item, which is item 8, performance monitoring. Amy, are you going to lead on this? Oh, Luce, great.
Thank you, Chair. Thank you. I think we've kind of, some of my thunder might have been stolen from our last conversation, because understandably, as Sue described in her report, our target operating model is largely predicated on, our prevention and our promoting independence agenda. But this particular report, as clearly, because you go through these regularly, this is reflecting on specific performance data for August of this year. So I have brought in some of the information that Sue has referenced, but I'm also looking at that specific month's reporting. So what I've tried to do in the headlines is just kind of tease out those bits of our measures which really relate back to our target operating model as best I can. So that's really around our early help and prevention offer, our promoting independence, but also our statutory offer as well, making sure we're offering our safe statutory service, which of course is priority number one. As a general kind of view, I think that what we are starting to see this financial year is some real shoots of hope, I suppose, and improvement, which is being sustained across a lot of those areas of prevention and prioritising, promoting independence. So really encouraging, still a long way to go, but there are signs of sustained improvement, which are great. So I don't want to duplicate, but I will try my best to skip through. So within the common access point, obviously we've talked about that quite a bit. One of our key indicators is about those people that we can help with that kind of one contact, but as Sue described, that's not necessarily one call, it might be multiple, and there might be multiple people involved. So, that's been really successful. And I suppose to pick up on a point in Sue's report as well, and I think we touched on it when I came to share back our annual return, our number of contacts into the common access point overall has reduced. But just to reiterate, that is by design. It's a really good thing. We've reshaped and reframed what we're there to do at the front door, and we've got a much better offer for our communities as a result of it, because they can go directly to their social work teams rather than go to the front door. So this is why that might look a bit odd, and in that statistic. So, but of our referrals that are coming through, which are deemed as social care referrals and integrated therapies, as Sue described, there's a number of different routes that these can take. We do offer information and advice, which is great. We also offer that community wellbeing advice at the front door as well, which is a bit longer and a bit more involved, to offer a bit more support. But as Amy mentioned as well, we do have our statutory offer as well. We have our rapid response MDT function at the front door, which is able to offer a bit more intensive support. But overall, we are seeing really good outcomes, especially with that, layers of early help and intervention. We're recognising things, obviously life is extremely complex. We rarely get contacts into the front door or our common access point which are regarding one distinct issue or problem. It's never as simple as that. People aren't straightforward. So it's always complex. There's always multiple bits of information and support that we can offer, but also the longer term kind of intervention is really helpful at that front door point. Do feel like I'm repeating things, but with reablement, our home care, I suppose, just to emphasise the point that we want to grow the amount of community referrals that we have into home care. Clearly, we also have huge demands coming through our hospital pathways. That's a balance, and that is still something that we're trying to strike the right balance with. Just to touch on some of the improvement work. So we're seeing a good increase in the number of people coming onto our books in our reablement at home, which is excellent. We've seen an overall, for August, we saw an increase in hours delivered and an increase in client numbers as well, particularly when you look at it compared to the previous end of the last financial year. What's really encouraging as well is that actually we're maintaining a length of stay, and that basically means the period of time that someone's with us in reablement. So we're offering that right support, and I think it goes back to the councillor's point earlier about how do we make sure that we are offering the best, most robust approach to people who are going through kind of reablement services. And in those cases, we are having multiple professionals involved in working with individuals, and we're managing to make sure that people are moving on to the next step at the right time, which is just as important as coming into the service at the right time. So the flow with our reablement means that we can bring more people through that system, of course, which is important, but it also means that people are getting the right intervention at the right time, which is great. In terms of statutory services, we have seen an improvement in terms of our initial assessments completed and a reduction in our waiting list compared to earlier in the year. I'm happy to say that for September, we've seen a further significant reduction in our waiting lists across social work assessment. I appreciate we're not talking about September stats here, but I have flagged that it's an area that we are working very hard to reduce. So just to mention that we have seen a reduction down to 390 from when this report was produced. And in terms of our initial assessments or new assessments, so those people that are brand new to social care and awaiting an assessment, that's at 154. It's still not where we want it to be by any stretch, but it is moving in the right direction. So work continues to bring that down further. In line with our target operating model, our carer support continues to improve. We've had 99 carers identified in August, and 93% of those offered a carers assessment in month. Carer support plans in place grows month on month, and we're now at 519. To put that into perspective, the same period last year we were at 283. So we're seeing again an improvement in the right direction. Our reviews. So reviews are challenging for us. We've talked about it here before. So again, we know there's still room for improvement. We've got just over 3,500 people with an active care and support plan. And at August, we were at 65% of those that had a review within 12 months. We understand some of the pressures in terms of our reviews. Our demand is huge, and it's largely around reassessments, oddly enough. So we're seeing a lot of demand coming into our system. We're working at the front door to improve new contacts, but we still have a lot of work to do with our people who are currently in our system. This is partly down to as well our different pathways to service. Part of that, not all of it, but part of it as well is about our timely discharges from hospital. People who have got an existing package of care, for example, and we want to restart them, so they're returning home and we want them to have the same carer, the same provider. They're coming out, but their needs have changed. That prompts what we call a reassessment. That bounces to our community teams. That's a lot of demand on those teams, just as one area of example. So we're doing a lot of work to improve that system, to try and divert that demand away from that team, to free them up with the capacity they need to conduct timely reviews, because we appreciate how important they are. And then lastly, just to conclude with some of our statutory interventions, safeguarding referrals did drop during August. And we also saw 84% of determinations completed, 83 of which within the target 7-day period, which is a slight improvement on previous months. Likewise, we continue to see a movement in the right direction around doles. So we've continued to reduce backlogs. I think it was around this time last year, a report was brought to Scrutiny panel around doles, and the peak, which we've recorded here is in February, was at 259. We've now got, for August, it's down to 73. And I think I'm right in saying for September, that's reduced further again. So good work from the doles team. Those are the headlines, Chair, altogether. Thank you.
Thank you, Luce. Are there any questions? Tony?
It's not a question, Chair. It's an offer. I think I did mention that it was the Welsh Institute of Health and Social Care that a number of years ago started to deal in the currency that we're now talking about. Just down the road is Professor Morton Warner. He's still alive and very happy to come and help colleagues in the health and care business if they want to use his talents or his information systems or wants to have a session. If you felt that would be useful, then Morton and I tend to get together about every 5 or 6 weeks for a bit of lunch in either in Swansea or Cardiff. And I'm sure Morton would be very happy to come and answer any questions or delve into his magic books of taboos from the years of gone by. And if you felt that would be useful, I'd be very, very happy to set up a link between you, or just let you have his phone number, and you can have a conversation either along the motorway somewhere or here, I guess.
It's an offer you can't refuse. Are there any other questions? Got off easy. Got off easy. A lot of the questions I had you answered, and so yeah. Thank you so much again. Yeah, thank you, Lucy. Sure, there's no more questions. Okay, we'll go on to item number 9, which is the work plan. Are there any comments? No, fine. Oh,
Sorry, can I suggest, or just, suggest something to add to the work plan if possible? And we've had 3 inspections from Care Inspectorate Wales on our registered services, and I think it just periodically we bring them here, and I just think because we've had 3, so we've had an inspection on 2 of our residential homes, St John's and the Hollies, in the past few months, and we had a joint inspection on one of our mental health teams, which was done by Health Inspectorate Wales and Care Inspectorate Wales. So it's predominantly health focused, but actually it's to do with our social work teams as well. So I just think if we bring a report either in the December meeting or January, whatever works, I guess if we work with the team, but it's on the terms of reference. I'm sure that we bring those periodically. So, or
thank you, Amy. Okay, Liz. Yeah. December. Yeah. Any other comments on the work plan then? We've got deprivation of liberty safeguards and internal day opportunities coming up. So I thank you all for attending and close the meeting. Thank you.
Thank you, Chair.
Thank you. Bye.
Bye.
Bye. Bye.